If you look at someone in the top 2.5% of the population for VO2 max and compare them to the bottom 25%, you actually have a 5-fold difference in terms of the chances of them dying from any condition over a 10-year period.
Welcome to Real Health. Before we get stuck into the podcast, if you want a chance of winning a €500 one-for-all voucher, head to mypodcastfeedback.com, pop in the code HEALTH and fill out our short survey for the chance to win a €500 one-for-all voucher. Folks, heart health is essential, especially when we look at the frightening figures. 10,000 people die in Ireland from cardiovascular disease every single year, accounting for 36% of the deaths. Heart, an Owner's Guide, is an engaging introduction to heart health where the goal is to live longer. Author and consultant cardiologist based in the Blackrock Clinic, Dr. Paddy Barrett, who also has a weekly Substack with over 20,000 subscribers, joins me on the podcast. Paddy, how's it going? How are you?
All very good. Good to be here.
I'm looking forward to this episode. We've had you on before. We were very lucky to have you on. You're a fascinating guest to bring on. What made you write the book? Let's start there. Is it as scary out there as those numbers and stats would have us believe?
I think it's two equal measures of scary and benefit for opportunity. The way I look at this is that the two statistics that everyone should really be aware of is, as you introduced at the start, cardiovascular disease is the leading cause of death globally and in most developed nations, but it's also the most preventable in terms of 80 to 90% of it can be prevented at an early stage if you just follow the right steps and formula. So I look at it as a scary opportunity.
And is it fair to say that no matter what age you are, you can, obviously, presumably if you start earlier, the better, but regardless of age listening in, you can reduce your cardiovascular risk factors at any age profile?
That's correct. But the analogy that I like to use is you have to think of it like a pension. You can, of course, make contributions to your pension later in life, but the compounding benefit that you get will obviously be much less. So if you are basically investing in your pension at a very early time point, you get a much more exaggerated result in terms of returns and reduction in risk. And the reason that that is important is because although cardiovascular disease is super important at the later stages of your life, coronary artery disease, or the disease that actually causes the events, is building up throughout your life, even starting in kind of early teenage years and sometimes documented even before.
Wow. Okay. Yourself and Owen McGee would get on very well. We've had Owen on the show all about pensions before. Cardiovascular disease, so let's start with that. What definitively is cardiovascular disease?
So there's often a lot of confusion here: cardiovascular disease, heart disease, etc. When we talk about this, it's really coming down to what's called atherosclerotic cardiovascular disease, which sounds like a really kind of fancy, scary term, but ultimately that is the technical term for plaque in the arteries. And we're talking here about plaque in your coronary arteries or your heart arteries. The issue is that when people have risk factors, think, cholesterol, blood pressure, diabetes, the more risk factors you have, the higher likelihood you will develop plaque buildup in your coronary arteries. And the earlier you will build up plaque in your coronary arteries. The more plaque you have in your coronary arteries, the higher the risk of an event like a heart attack or a stroke. So we always have to be careful in terms of making the distinction between risk factors, high blood pressure, cholesterol, diabetes, the disease, which is coronary artery disease or plaque in your coronary arteries, and the thing that we're trying to basically prevent, which is the event of a heart attack or stroke. And the simple formula is you minimize the risk factors to delay the onset of plaque in your coronary arteries as long as possible to minimize the chances of an event. And it's really just applying that formula whereby you can take the leading cause of death right down the chain and actually minimize your chances over time.
And checking for that plaque buildup, is that a calcification score? Is that how we check for that?
So that is probably one of the most commonly used tests, description being really a cardiac CT, which is two components, a CT coronary artery calcification score, and also a CT coronary angiogram, which looks in more detail for non-calcified plaque and other details. The key distinction here, though, is that if you're using the model of healthy centenarians in terms of those who live very long lives without major chronic diseases, the key takeaway we have received from their research is that they get the same diseases as everybody else: cardiovascular disease, cancers, and dementia. The key difference is they get them 20 to 25 years later. So you're looking to defer the onset of the disease. So a cardiac CT is looking for the disease, But if you're just waiting for the disease to present and then aggressively treating it, you've really missed that window of opportunity to defer it as late as possible. So while a cardiac CT is really important in terms of looking at whether you have the disease and how much and what that means for your risk of a heart attack over the near term, the real leveraging of risk reduction comes from managing the risk factors much earlier in life, when you're likely to not have any plaque in your coronary arteries visible on a CT scan. And when you manage those risk factors, then you delay the likelihood of the buildup of plaque that we would see on a scan, and ultimately the risk of an event like a heart attack.
And those risk factors and getting to them as early as you can, that brings us into that health span concept that you talk about.
Well, I think we need to make the distinction between these metrics. In my view, health can be characterized by the optimization of three factors: lifespan, how long you live; health span, the quality of your life in terms of how you physically move and think in the world, and that's basically the avoidance of major chronic diseases, including dementia. And then soul span is this idea that with a long life of high quality, what are you going to do with that time? And for me, that's arguably the most important question, because we're all working to live longer with a higher quality of life, but fundamentally you have to use soul span as your motivation for why, and that is the basis for all of this, because we have to ask ourselves what we're going to do with that time. And so specifically to answer a question around health span is the avoidance of a major chronic disease, maintaining your functional capacity in terms of what you're able to do physically, and also cognitive capacity in terms of how you use your mind over that period of time.
Soul span, I like that. I've never come across that one. I love hearing new concepts. That's fabulous. So for people listening in, it's not necessarily about living longer if you don't live well as you get older, isn't it? That idea of living well longer, being able to do the things that you want to do as long as possible.
Well, and again, but we have to split them across different domains. Everybody in their life knows somebody who lived a long life, but maybe had a major chronic disease. So their quality of life in terms of what they could physically do or cognitively do from a dementia perspective was reduced. And then there are people who live maybe a short life, and maybe even their health span was reduced, but the way that they lived their lives was an incredibly intentional life, and they really extracted all the maximum value from it. So you have to ask, in terms of what your goals are and what you're trying to achieve, I think for most people who are interested in health, they want to live as long as they can with the greatest amount of physical capacity and cognitive capacity, and then to really ask themselves what they're going to do at that time. For me, that becomes the motivation as to why you would do the hard things required to have the motivation to actually get your risk factors in place. And that is really around using kind of the lifestyle approaches of exercise, nutrition, sleep, and stress. And they're kind of the four key pillars. And if you optimize those four key pillars, most of the risk reduction can be achieved. And then for a small number of people, they will actually have, say, genetic predispositions that give them a risk factor that may require a medication to be layered on top of that.
Is cardiovascular disease a result of the modern life that we live, i.e., we're more sedentary, we eat more ultra-processed foods, we have poor sleep, we're addicted to social media? Is it linked to that modern lifestyles that we lead now?
It's not. If you actually look at CT scans that were done of Egyptian mummies that are 4,000 years old, they had multivessel coronary artery disease, and some of them had it as early as 40 years of age. So although our modern environment incentivizes to behave in ways that actually increase our risk, there's no doubt that cardiovascular disease and heart disease has been with us for thousands and thousands of years. Now, historically, it wasn't a leading cause of death because other conditions actually killed people. So if you looked at historical periods of time, most people died from infectious diseases. But if you look at contemporary periods, 90% of people will die from a non-communicable disease, and most likely it will be cardiovascular disease, cancer, or dementia. And so really just looking at this on an actuarial math basis, you say, listen, these are the leading causes of death. We know that there are solid inputs that we can use in terms of managing blood pressure, blood sugar control, exercise, nutrition, etc., that can actually decrease the risk of not only cardiovascular disease, but also many cancers and certain dementias. And so you get the aggregate benefit of that.
And it really comes back to then that idea of living with intention, or trying to be well with intention, finding that why. That's, just chatting to you already, that's really what it's coming back to, isn't it? Finding your why to eat better, your why to lift weights, your why to sleep better. That's a crucial part of cardiovascular disease prevention and wellness, for lifelong wellness too.
Well, this really comes back to, like the famous authors that have been talking about this, Charles Bukowski and the Stoics, kind of the Greek philosophers, etc. If you don't decide what you're going to do with yourself, the world will tell you what to do. And generally, that won't be a good outcome for you. And most people's dissatisfaction really is that separation between their expectation and their reality. And most people intrinsically know what it is they want to do at some level, but the world basically incentivizes to behave in ways that is often at odds with that. As Charlie Munger says, basically, show me the incentive and I will show you the outcome. And so if you don't go at this with a very intentional approach, you will be led to directions that are going to be bad for your health across all the domains of lifespan, health span, and soul span. And so you need to set very clear goals. If you don't have a clear destination, the likelihood of you landing at that destination is very low. And that's really what the book is about. It's about asking yourself, what is your goal? How do you intend to hit it? Are you hitting the actual metrics of input across the risk factors in terms of exercise, nutrition, sleep, stress, cholesterol, blood pressure, blood sugars, etc.? And are you then going to get the benefit from that? And in what serving what need for you in terms of your goals, in terms of health span and soul span with that?
Was a cardiologist always your goal? Was that always your plan?
Well, I think. If I think I always wanted to be an air sea rescue helicopter pilot, but yeah. So that was my original goal, but I couldn't actually do that because I didn't have 20/20 vision at the time. All the recruitment for air sea rescue helicopter pilots was through the Irish Air Corps at the time. I then decided I would do something different and became a doctor instead. I think from it wasn't from an early age that I wanted to be a doctor. It was something I only thought about later in life. But yeah, so I just found myself in kind of the area of cardiology, and it's served me well ever since.
That was a random question, purely because anytime I chat to you, anytime I follow your stuff, your passion just shines through, and I'm always intrigued by people who have such a graw for what they do. It's always interesting to ask them if that was their plan. Back to the book. Was it always your intention to put a section on the structure of the heart in the book? Is that important to educate people about the structure of it, as well as the content about health span and soul spans and stuff?
So I think there's certain core concepts that people need to lay down as a framework so they can understand what they're talking about. Just like the question you asked me about heart disease, people know the term, they hear it used, it's used in the media, but often there's not a clear understanding of what it is that heart disease actually is. Heart disease can relate to many different things: issues with the valves, issues related to kind of the actual heart muscle, and a whole variety of different components. It was actually the publishers who pushed me more to include those anatomical features, but because for me it just was easy. It was something that kind of I have ingrained in my mind, but we tend to forget the core fundamentals are not as obvious to other people, and they're crucial pieces of the framework to understanding how things work. Because if you don't understand the problem you're trying to solve and the pieces that it's made up of, the likelihood of you being able to put in place a solution to that is much lower. So that's why that is included at the start of the book, really to give context to what we're talking about.
One of the things we haven't chatted about is the genetic component to heart disease and cardiovascular disease. Talk to me about that.
So genetics are really important when it comes to cardiovascular disease. But in general, we all were taught Mendelian genetics about kind of some Franciscan monk, growing peas. And basically it was either you had the gene and then you got the disease, or you didn't get the gene and you didn't have the disease. Modern diseases, including cardiovascular disease, are often much more complex, and genetics give us a probabilistic increased risk rather than deterministic. And what I mean by that is that if you have certain genes for cardiovascular risk, it increases that risk, but doesn't necessarily guarantee you will get the disease or the event. So it's always important to look at it that way. We know that even for those with significant risk determined by their genetics, with the right lifestyle factors, you can reduce the risk by about 50% at least. So again, genetics loads the gun and lifestyle pulls the trigger, as the famous line goes. So it's not actually determined that even if you see, that there is a strong family history of heart disease in the family, it doesn't imply that you were on that exact same path. You may be at an increased risk and you may need to be more aggressive earlier in life, but it doesn't mean that you are kind of set on a very determined path. The two key points to get across when we talk about genetics and cardiovascular disease is number one, around cholesterol. About 60% of the variability of your cholesterol is genetically determined. So frequently people go to their doctor with high cholesterol. They change all their lifestyle. They do all the right things, which are really important things to do. But the impact it has on their circulating cholesterol levels is often modest. For some people, it's large, but for most people, it's modest, and they get very frustrated. But that is because a huge percentage of it is driven by their genetics. The second thing is that probably the most common genetic cholesterol disorder in the population is what's called an elevated Lp(a) or lipoprotein A, and it impacts about kind of 10 to close to 20% of the population. And it is very infrequently checked. So this is one of those things that I think most people are surprised to hear when I hear the story, dad had a heart attack at 40 and his dad had a heart attack at 40. This genetic condition, which is very common but infrequently checked, is often the explanation and an important arbiter of risk. So they would be my main takeaways when we think about genetics and heart disease.
Another one of those risks then is visceral fat. So just tell us a little bit about what that actually is and why it's a problem.
So when people talk about the risk of heart disease related to excess weight or obesity, what we're really talking about is the excess fat that is what's called visceral fat. And you have two types of fat. There's subcutaneous fat, and that is the stuff that's on your side that you can pinch. And although people may not like the appearance of that for some people, it contributes very little to your excess risk in terms of heart disease and diabetes and high blood pressure, etc. It's the fat that is actually inside your abdominal cavity that is the engine of inflammation that drives cardiovascular risk. And for people who are, say, overweight or have obesity, there is obviously a higher chance they will have excess visceral fat. But there's also groups of individuals who have less subcutaneous fat, but a significant amount of visceral fat. And so they don't appear to be overweight by any obvious metrics, but they're carrying excess visceral fat, which is driving their risk of heart disease. And this excess visceral fat really kind of drives a condition called insulin resistance, which acts as a massive amplifier of risk for all the major chronic diseases, cardiovascular disease, many cancers, and dementias. And so it's not that it is the exclusive cause of these conditions, but it is very much the amplifier of risk. So you have to think about it as the gasoline that is poured on the fire.
And if people want to measure their visceral fat, it's a smart scale. It's either in a pharmacy or at home that will give you a decent indicator, a rough indicator.
So with everything in life, there are accurate ways to do it that are obviously complex and sometimes expensive. And then there are much more simple ways that don't have the same accuracy. So we always have to ask which test we're using. Arguably, the simplest test is to measure your waist circumference. That is the circumference of your abdomen around where your belly button is, rather than your jean size. And really, this is where kind of having excess, people describe it as belly fat, but really it's that fat in your abdominal cavity that actually increases risk. And so often people will see, you may have excess fat on your buttocks, for example, but that's subcutaneous fat, and it doesn't add really significant excess risk. So the easiest way to do it is your waist circumference enlarged. The metrics vary by country, but generally, if it's greater than 35 inches for females and 40 inches for males, I could be saying that incorrectly, but this is the circumference around your waist at the level of your belly button.
It's that kind of body shape concept, isn't it? It's the apple shape versus the pear. That apple shape is a riskier shape from a health perspective. That kind of pear or Latino kind of shape where the bone and the hips carry the excess fat is a much healthier body shape.
Correct. And that's to do with the distribution of or where fat is in your body. Females tend to accumulate fat predominantly in their buttocks and thighs, and that doesn't significantly increase risk, whereas males often increase it or have that distribution of fat in their abdominal cavity, which is excess visceral fat. Now, the reasons for that are somewhat unclear, but one of the evolutionary reasons is that females actually have to carry children in their uterus, so they distribute fat away from that area where males actually don't. So that's one of the theories.
Okay, so about this is a very simplified level. If you are an apple shape, you are at higher risk of a higher visceral fat and a higher risk of cardiovascular issues later in life.
Correct. And we can go up the chain of complexity in terms of how we evaluate this. The most complex way is to, and the most accurate way is to do something like a DEXA scan, as long as that DEXA scan has software to actually give you what's called a VAT mass, or visceral adipose tissue mass. And so you can then benchmark it against percentiles for age and sex. MRI scans of the abdomen will be able to calculate similar features. But arguably, probably one of the easiest ways to assess whether you have excess visceral fat is to see that do you have any of the downstream consequences of having excess visceral fat, and that is the features of insulin resistance and metabolic syndrome. So metabolic syndrome is a set of characteristic features that actually indicate whether you have the consequences of excess visceral fat. And metabolic syndrome is basically having any three of the following 5 features of high blood pressure, high triglycerides that you see in your cholesterol test, low HDL, or often referred to as good cholesterol, abnormal blood sugar levels, or an excess in terms of waist circumference. So if you have any 3 of those features, you meet the criteria for having metabolic syndrome, which significantly increases your risk of cardiovascular disease and other major conditions. But we know that even having one of those features does increase your risk. The encouraging thing about that is that although it significantly increases your risk, there's still a huge amount you can do, particularly from a lifestyle point of view, to actually decrease that risk.
And one of those lifestyle factors is aerobic fitness. That's a really important aspect from a lifestyle perspective to keep an eye on a personal perspective, isn't it?
Well, so when we think about fitness, there's multiple domains, and we have to think about what your goal is. I mean, if your goal is to be a 100-meter sprinter, your fitness targets will be quite different to if you want to be a shot putter or a different kind of sporting event. But for me, my fitness goals are around functional longevity. That's living longer and having a higher capacity to do those things later in life. So if that is your goal, we know that very high levels of aerobic fitness, which are traditionally measured by metrics like VO2 max, have some of the highest predictive capacity and biomarkers for longevity. If you look at someone in the top 2.5% of the population for VO2 max and compare them to the bottom 25%, you actually have a 5-fold difference in terms of the chances of them dying from any condition over a 10-year period. And even if you're just in the top 25% compared to the bottom 25%, there's a 4-fold difference. So that difference is obviously a huge difference in terms of the likelihood of dying from any condition and also cardiovascular disease. It's something that is trainable, and it's certainly something that people can move up the scales, and they get most of the benefit in really getting off zero rather than kind of being frustrated with this idea of maybe not making the top 2.5%.
And of course, food then is a really important factor in all of this as well. What should people be eating, or what shouldn't they be eating?
So again, this for me actually goes back to the visceral fat question. I think if you look at a lot of the nutritional epidemiology studies that we use to answer this question over very long periods of time, it's, in my view, not very reliable data. And so people get obsessed with should they eat X type of food or Y type of food. And for me, the issue with nutrition is that being in a condition whereby you eat so much that you have excess visceral fat, that is the thing that is driving most of your risk rather than the actual constituents of what you're actually eating. So for me, and it's always unpopular to say this, but it comes down to your energy balance. And are you meeting your appropriate energy balance? And that comes down more so to calories. So for me, when I look at this and people are trying to lose weight to reduce their risk, my first question is what is your calorie target, which can be worked out on loads of online free calculators. And then you ask, what is my protein target for this in terms of your approach to reducing weight? So am I hitting my calorie target? Am I hitting my protein target? And then when we look at the mixture of fat and carbohydrates, you really have to balance that in terms of your preference. So I think people get caught up in terms of eating a low carb diet or a low fat diet or a vegan diet or whatever. But fundamentally is, are you hitting your calorie target? Are you hitting your protein target? And are you making up the difference in a way that is sustainable for you, that you can work with over time, and that doesn't cause any of your biomarkers to go crazily out of whack? And what I mean by that is that for certain people, about 30 to 40% of patients on a ketogenic diet, their LDL cholesterols will go exceptionally high. And in my view, that does expose them to increased risk over longer periods of time. But it's far more simple in my view. It's hitting calorie and protein target and then using a dietary strategy, however you want, that becomes a sustainable pattern for you.
I love having you on the show. You could talk all day and I could listen to you all day. You just have content and simple content. It's absolutely fantastic. And we're delighted to have you back on. So we really appreciate you taking the time. If people wanted to jump on your Substack, how and where can they do that?
Just type in Dr. Paddy Barrett newsletter, or you can follow me on Twitter. Just type in Dr. Paddy Barrett on Twitter. You can find me there. And I think there are two good places to start with any of the following.
And you're on Instagram as well. I follow you on Instagram too. Your posts are fantastic. Paddy, it's been great to have you back on. We really appreciate it, and thank you so much for joining us on today's show, folks. I really hope you enjoyed today's episode. Solid content from an absolute expert in his field. As ever, you know where we are, at Karl Henry BT on Instagram, Real Health on the Irish Independent website. We'll see you next week for more Real Health. So long, good folk.